Good morning. I'm Dr. Ricardo Careillo Meza, medical graduate from the Autonomous University of Baja California at Mexico, and I'm presenting CARDASL. CARDASL means cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. This disease is the most common monogenic cause of adult onset progressive cerebrovascular disease. It affects approximately 2 to 5 of 10,000 people. This term is kind of recent. It is coined in the 1993 by Bowser, yet as early as the 70s, families who present with an unusual clinical presentation of cerebral small vessel disease were described in the literature. The cause of this disease is a mutation in NOTCH3 gene on the chromosome 19. It is characterized by a small vessel failure in the brain and cognitive impairment. We will talk a little bit about NOTCH3. NOTCH3 protein and gene. The gene encodes for a single pass transmembrane receptor that is expressed on vascular smooth muscle cells, which act as a signaling receptor to control cell fate in many developmental and adult tissue contexts. Within its developmental roles during vascular development, NOTCH3 regulates that endothelial precursor cells differentiate and form tubular networks. And during angiogenesis, these networks undergo sprouting and vessels are stabilized by mural cells, which will differentiate vascular smooth muscle cells, playing an important role because NOTCH3 promotes proliferation and protects against vascular smooth muscle cells apoptosis. Below, we can see on image A the relationship between different cell types that comprise the blood vessels, and on image B, the different layers of the vessel wall. As with other notch proteins, there are total 4 notch proteins. We are talking only about NOTCH3. NOTCH3 continues to function in various capacities in the adult organism. Its role in neuronal stem cells and neuronal differentiation implies maintenance of quiescent stem cells by suppressing their proliferation and regulating adult hippocampal neurogenesis. In adult mice, NOTCH3 is expressed on neural stem and progenitor cells in the subgranular zone of the hippocampus and the subependymal zone of the lateral ventricles. On the first series of images, we have the subgranular hippocampal zone, which main function is to carry out hippocampal neurogenesis. On A, you can see that this zone extends from the border of the hippocampal dentate gyrus and the ileus. And on B and C, you can see cells from this region on different stages of neurogenesis. And on the image from the left, we have the other zone, the subependymal zone, which is an important stem cell niche in the adult mammalian brain. This zone contains active and quiescent stem cells. NOTCH1 is preferentially expressed in the active stem cells, while NOTCH3 is preferentially expressed in the quiescent cells. And although detailed analysis in human cells and tissues is still lacking, this already suggests that NOTCH3 might exert regulatory influences on neuronal plasticity. NOTCH3 is important also for having a healthy vascular function, maintaining vessels and blood-brain barrier. And there is evidence for supporting the role of NOTCH3 in mediating mechanotransduction. Mechanotransduction refers to all the processes through which cells sense and respond to mechanical stimuli by converting them to biochemical signals, and that elicit a lot of specific cellular responses. For example, when vascular smooth muscle cells are in contractile condition, they regulate vascular tone. But in adaptation to mechanical inputs, these cells can switch morphology to a synthetic phenotype and contribute to vascular growth and remodeling. And there are other functions that NOTCH3 has, as regulating satellite cells, which are stem cells involved in skeletal muscle repair. And also, NOTCH3 has roles in esophageal homeostasis, promoting esophageal squamous cells differentiation. Now, considering the important role of Notch signaling in vascular development and homeostasis, it is logical that dysfunctional Notch signaling has been observed in a number of many vascular diseases. On the left, we have diseases linked to mutations or aberrant regulation of NOTCH3, and on the right, the linked ones to other genes in the Notch signaling pathway. We can see that NOTCH3 is involved also in pulmonary arterial hypertension, childhood primary hypertension, patients with cerebral small vessel disease and white matter lesions, while the general Notch signaling pathway is involved in cerebral cavernous malformations, neural tissue hemangioblastoma, thoracic aortic aneurysms, arteriovenous malformations, glomus tumors, and other diseases like the multi-organ diseases with vascular problems as Alagille syndrome and Adams-Oliver syndrome. The role that plays NOTCH3 on CARDASL is this one, that mutations of this protein cause an accumulation of its extracellular domain, causing its segregation around vascular smooth muscle cells and pericytes of brain arteries and capillaries. On image A, a small artery from white matter is immunostained with an antibody raised against the extracellular domain of NOTCH3. We can appreciate that the vessel wall is thick. We can see the generation of smooth muscle cells and aggregates of NOTCH3 that are pointed by the arrows. On image B, the arrows are pointing to many deposits of granular non-amyloid osmophilic material that are characteristic of this disease. About its clinical presentation, all larger studies have demonstrated that brain ischemia is the most frequent symptom in CARDASL. It occurs between 50-65% up to 85%. Being symptoms of focal brain ischemia the most common complaint. On other cohort studies, around 28-44% of patients have been diagnosed with cognitive impairment, being domains of most significant vulnerability, the ones of executive function, attention, memory, language, and visuospatial function. In addition, a higher incidence of up to 40% of migraine with visual aura has been reported in CARDASL patients compared to the general population. And neuropsychiatric manifestations of CARDASL include depression, apathy, and anxiety. Being depression found in around 20-30% of the patients, and apathy in 41% of them. And similar to other vasculopathies, the velocity of deterioration and progression to dementia is variable. Sometimes, the majority of times, it has been found that 85% of patients did not show a significant worsening in a 2-year prospective study after the diagnosis. But there's a small percentage, less than 5% of the patients, that worsen dramatically in the same period of time. Following with the progression of the symptoms in CARDASL, the pace of cognitive dysfunction is progressive, and it can extend over decades. usually. And of the previously mentioned cognitive domains, aphasia and memory deficits are uncommon until late in the disorder. And as the disease progresses, patients exhibit diffuse spasticity, dysarthria, dysphagia, emotional incontinence, gait abnormalities, and global cognitive disability. On the left, we can see the natural history of the main clinical manifestations of CARDASL, being migraine with aura present early in life. Because migraine with aura is common in general population, the symptom by itself is generally not helpful in establishing diagnosis, even though it is a common symptom that occurs early in life in patients with CARDASL. When this migraine with aura is present, is usually the first symptom, with an average age of onset of 30 years. As mentioned before, ischemic strokes are really frequent, including also TIAs, transient ischemic stroke attacks. These events, as you can see on the image, occur at a mean age of 49 years in most of the cases, in the absence of conventional vascular risk factors. Something that characterizes people with CARDASL is that the majority of them don't present with cardiovascular risk factors. The percentage of people that present with these increased risk factors is around 20%. Then we have mood disturbances and apathy that generally are present as severe depressive disorders that sometimes alternate with maniac episodes that could be mistaken for bipolar mood disorder until the typical CARDASL abnormalities are seen on MRI. Apathy will be characterized by absence of motivation that is associated with decreased voluntary behavior and is considered as a major clinical manifestation of CARDASL. By last, cognitive impairment is the second most frequent manifestation, being the early sign in most of the cases of impairment in these cognitive domains, and is characterized by executive function and processing of speed in a more slowly manner. Cognitive decline will become more extensive with aging. As you can see, it progresses through time. It will worsen with the recurrent stroke. And in the years preceding death, dementia is invariably associated with motor impairment, gait disturbances, and later, cerebral palsy. Finally, on the bottom, we have T2 white matter abnormalities that increase progressively and becomes constant by around 35 years in all patients. The exact age at the earliest onset is uncertain. That's why the dotted line. But basically, after the 35 years of age, all patients present with this type of abnormalities that we'll see soon. On a retrospective study that included 411 patients, with the data from the patients who had passed away, life expectancy was reported to be reduced only by 5 years for men and between 2 to 2 years in women. But if we look at table 4, we can see what the clinical status at onset of the cause of death was, being frequent for the majority of patients, over the 70%, to present spastic tetra or hemiparesis, dementia, dysarthria, dysphagia, urinary and fecal incontinence. And on table 5, we can see what the primary causes of death were in 50 patients. That information could be verified. Being the most common cause, pneumonia by 36%, if we consider pneumonia and aspiration pneumonia as the same, and is followed by a sudden unexpected death with 25%. The diagnosis of CARDASL requires radiologic and clinical correlation Although the severity and timing of symptom onset varies in CARDASL, it is a highly penetrant disease with a clinical and radiologic manifestations that present in the vast majority of patients by late middle age. By late 35 years, they will be present with these characteristics that we will see. The best imaging study to study CARDASL will be MRI, but we need to be aware of what manifestations will be seen in a CT scan. On computed tomography, in early stages of CARDASL, non-specific periventricular and other subcortical white matter hypodensities may be seen, and the characteristic white matter disease will not be evident on computer tomography until more advanced stages of the disease. We can see on the first image, on image A, periventricular and subinsular white matter hypodensities. On B, bilateral anterior temporal pole subcortical hypodensities that are better seen on the coronal view on the third image on C. These ones are from the same patient. And now we will study MRI. Brain magnetic resonance is the most clinically relevant imaging modality in CARDASL. In the early stages, it will be similar to the CT scan. We will see non-specific periventricular and other subcortical hyperintensities seen on FLAIR, and that may be distinct from changes related to other small vessel diseases. However, on advanced stages, the typical presentation are confluent white matter FLAIR changes. We can see them on A and B images. We can see that there is abundant white matter and periventricular white matter disease. And on C, we can appreciate involvement of the external capsule. And on images D and E, we can see confluent anterior temporal pole white matter involvement. And on F, subcortical microbleed is seen as a punctate rounded hypointensity on fast field echo sequence. Continuing with microbleeds, on A, we can see a small hypointense foci on the brainstem, and on B, these microbleeds are in the thalamus. On CARDASL, we can also see these lacunar infarcts. Here we can see lacunar infarcts on image A in the pons, on B in the thalamus, and on C in the lentiform nuclei. The last lesion I want to show you is this one. Here we can see multiple hypointense lesions at the cortico-subcortical junction that are lacunes related to dilated perivascular spaces. These lesions are the most specific features seen in CARDASL. They are present in about 67% of the patients and are associated with the white matter hyperintensities we saw previously on the anterior temporal lobes. And now we will review two CARDASL diagnostic criteria. Because this disease is not so prevalent, we don't count with many diagnostic criteria. The first one that is the most used is the Davos CARDASL criteria from 1998. It has a sensitivity of 52% and a specificity of 66%. It is very simple to use. If you see it catalogs the diagnosis as probable or possible, and it excludes effectively the diagnosis if the patient has a presentation we already know is not compatible with CARDASL, as onset above 70 years, severe vascular risk factors, or a normal MRI of white matter after age 35. On 2017, this criterion was published. Their authors named it the new diagnostic criteria for CARDASL in Japan. Criteria was validated in Japanese population only. It has a sensitivity of 97.1% but a specificity of only 7.5%. It is highly sensitive, but poorly specific, as you can see. More than a scale, this works as a summary of how CARDASL can be diagnosed. It also catalogs clinically the diagnosis as probable or possible. But what I want to highlight here is that how the definite diagnosis is made. The patient must fulfill white matter lesions on imaging. That he is leukodystrophy is not explained by other diseases. And the genetic criteria, which is the gold standard, or the pathological criteria, which both can be assessed by skin biopsy. And now we will discuss about treatment. Unfortunately, to date, there is no treatment of proven efficacy for CARDASL. Current treatments consist only on targeting cardiovascular risk reduction. Blood pressure has been identified as a negative prognostic marker for stroke onset. If you have hypertension, you are more probably to suffer from a stroke early in life. Smoking has been associated with poor outcome, and patients may benefit from statins and antiplatelet therapy. Regarding migraine with aura treatment, the management is similar to the one of general population, with the exception that beta blockers should be avoided for migraine prophylaxis in these patients, because it seems to demonstrate that the use of prophylaxis with beta blockers, specifically propranolol, conduces to worse outcomes. Also, depression treatment is similar to the one of the general population. By last, I want to show you the CARDASL Association and CARDASL Foundation, mentioning on each helpful resource for patients and or physicians. This one here is the CARDASL Association, a nonprofit organization named Cure CARDASL. If we scroll down in this webpage, we will find this menu. And from this option, let's click on Find a Provider. If we click on Find a Provider, this map will show up, providing you with a list that features clinicians based in the US with information provided by community members. And as you can see on the list, there are options for more than 5 patients. One example is the University of Washington Medical Center. And this one here is the CARDASL Foundation. This one is a nonprofit organization too. Its name is CARDASL Together We Have Hope. That unfortunately has discontinued operations after 16 years of work. But the webpage still works. And a great resource that provides you with information about testing sites in the US and all over the globe. Here, we can see an option in the US. The option is Athena Diagnostics, and also provides information from the other countries previously shown. These ones are my references. And finally, I want to thank you for your attention and your time.